Brad, you can go ahead.
Okay, great. Do you want to go back to the first slide? All right, welcome. Good afternoon, everyone. Welcome to the IARS Virtual Education Webinar, Perioperative Brain Health, Insights from Young Investigators, co-sponsored by ESAS, the Early Stage Anesthesia Scholars. This webinar has received no commercial support. CME is available for this webinar to IARS members only. Please join us in April for the IARS 2023 annual meeting, which will be held in Denver, Colorado. If you missed the IARS 2022 meeting, on-demand access to session recordings are available for IARS members only. Visit the website on the screen for more information. After today's webinar, visit the IARS member community on DocMatter to continue the conversation. A recording of this webinar will be available to IARS members by the end of the week. Please submit questions during the session using the Q&A button down at the bottom of the screen. You will receive an email after the webinar with information about obtaining CME credit. And now let me introduce our panelists. My name is Bradley Fritz. I will be moderating today's session. I'm an assistant professor at Washington University School of Medicine in St. Louis. Our first speaker today will be Dr. Mitra Heshmati. Dr. Heshmati is an assistant professor of anesthesiology at the University of Washington. She completed her MD PhD at the Icahn School of Medicine at Mount Sinai and BA-MS in neuroscience at Johns Hopkins University. Dr. Heshmati's research program goal is to develop a comprehensive understanding of anesthesia-induced brain plasticity to inform translational approaches for expediting emergence and mitigating delirium. Her laboratory investigates effects of general anesthesia on neural circuitry using whole brain imaging approaches, targeted biosensor imaging, and genetic manipulations in a rodent model. In 2021, she was awarded a FAIR Mentored Research Training Grant, and this year received an NIGMS MIRA R35 grant to support her laboratory's investigation of the mechanisms of emergence from anesthesia. Today, Dr. Heshmati will be speaking on dissecting midbrain connectivity in anesthetic emergence. Our second speaker is going to be Dr. Kathryn Rosenblatt. Dr. Rosenblatt is an assistant professor of anesthesiology and critical care medicine at the Johns Hopkins University School of Medicine and serves as director of the Neurosurgical Anesthesia Fellowship. Following her residency training in anesthesiology, Dr. Rosenblatt completed fellowships in neuroanesthesia and neurocritical care at Johns Hopkins. She also completed an NIH T32 research fellowship, earning a Master of Health Science in Clinical Investigation at the Johns Hopkins Bloomberg School of Public Health, and more recently has been awarded a Foundation for Anesthesia Education and Research Mentored Research Training Grant. She is the founding director of the Cerebral Autoregulation and Sepsis Research Group, a multidisciplinary team whose mission is to personalize and improve care of sepsis patients through a better understanding of the pathophysiology of brain disease in sepsis-associated encephalopathy. Today, Dr. Rosenblatt will be speaking on defining cerebral autoregulation-guided therapeutic targets in sepsis. Our third speaker will be Dr. Michael Devinney. Dr. Devinney is an assistant professor of anesthesiology and critical care medicine in the Department of Anesthesiology at Duke University. He completed his undergraduate degree at the University of Pittsburgh, followed by his PhD in neuroscience and his MD through the University of Wisconsin Medical Scientist Training Program. He subsequently completed anesthesiology residency and critical care fellowship at Duke University. His research aims to understand risk factors and mechanisms of postoperative delirium and cognitive dysfunction that could be addressed to prevent these disorders. He currently is investigating the role of untreated sleep apnea, blood-brain barrier breakdown, and neuroinflammation in postoperative delirium and cognitive dysfunction. This work is supported by a GEMSTAR grant from the NIA and FAIR. Today, he will speak on the SANDMAN study, sleep apnea, neuroinflammation, and cognitive dysfunction manifesting after non-cardiac surgery. Our final speaker will be Dr. Kendall Smith. Dr. Smith is an assistant professor at Washington University in St. Louis, Department of Anesthesiology. She completed her medical training through the MSTP program at the University of Kansas, followed by anesthesia residency and critical care medicine fellowship through the Academic Career Enrichment Scholars Program at Duke University. Dr. Smith is currently funded through an IARS Mentored Research Award, studying the role of disrupted circadian rhythms in postoperative delirium, postoperative and ICU delirium. Dr. Smith also received support for her work through the Washington University Department of Anesthesiology's T32 program. Today, Dr. Smith will tell us about her work to examine the role of the circadian clock system in maintaining perioperative brain health. So look forward to starting our presentations.
Thank you for the introduction, and thank you for inviting me to be part of this webinar today. Today, I'll tell you a little bit about my laboratory's new studies using whole brain approaches to investigate emergence from general anesthesia. I have no conflicts of interest to disclose, and these are the learning objectives for this talk. You may be asking, why should we be studying emergence in a rodent model? Well, emergence is still an unpredictable time in the course of an anesthetic, and we have yet to develop agents to predictably bring about a smooth and quick emergence. We also know that some anesthetics, such as the volatile anesthetics like sevoflurane and isoflurane, are more likely to produce emergence delirium in particularly pediatric patients, while other anesthetics like propofol are used to smooth emergence. In order to better understand how these anesthetics are working to produce emergence and also contribute to delirium, we need a better understanding of how anesthetics work across the brain. So the lab is now taking an approach called whole brain activity mapping to see a snapshot in time of neural activity across the intact adult mouse brain. So what you're seeing in the video are white puncta that are immunolabeling for CFOS, which is an immediate early gene and a marker for neural activity. In the bottom right, you see how the mouse brain looks when it's been processed for this technique. This allows us to take an unbiased approach to seeing all the activated neurons across the entire mouse brain with exposure to anesthesia and during emergence. So how do we do these studies? We expose mice to 180 minutes of isoflurane. We have one group that's deeply anesthetized and maintained at 1.2 to 1.5% isoflurane, while we have another group that we term the emerging group, which is a group that we induce with isoflurane, allowed to recover and emerge, as was shown by restoration of the writing reflex, and then maintained at 0.3%, mimicking the slightly anesthetized and emerging state. Our control mice are habituated to the anesthetic chamber but do not receive any anesthesia. After 180 minutes, the brains are collected, stained for CFOS, that immediate early gene, and then undergo a process of iDisco plus clearing to render the brain amenable to imaging with light sheet microscopy. These raw images are acquired and then resliced and aligned to a brain atlas that allows us to then take an unbiased and automated approach to analyzing the CFOS positive cell density across the entire brain. How does this data look? So here you see CFOS positive cell density on the y-axis across the grossest hierarchical subdivision of the brain. So for example, generally looking across the cortex in the far left panel, we see that there is a decrease in CFOS positive cell density in the deeply anesthetized group relative to the control and emerging group, reflecting a decrease overall of neural activity at the cortical level with isoflurane. Of course, the strength of this approach is that we're capturing this activity at the cellular resolution, so we can go even further in our analysis. Here I've just chosen 4 brain regions that have already been implicated to be important for maintaining the state of isoflurane anesthesia and for emergence. The top brain region is the central amygdala, and you can see in this heat map view of the FOS positive cell density, here is the central amygdala. You see an increase in FOS density in the deeply anesthetized group relative to the control group shown in green. That reflects increased activity in this brain region. Other regions, such as the ventral tegmental area here in the second panel, have been shown to be important for emergence and arousal. And we also replicate this data in our findings, where we see there's an increase in ventral tegmental area activity in our control group relative to the deeply anesthetized group. Other brain regions that stand out include the parabrachial nucleus and the locus ceruleus, which have also been shown to be important for emergence from anesthesia. And here's another depiction of this data and the ATLAS registration overlay. We can also then look at how significantly regulated is this activity. So these are p-value maps, and it's showing you in green regions that are significantly increased, have showed significantly increased activity in our deeply anesthetized group relative to control animals, whereas in purple are regions that have significantly increased activity in our control animals relative to the deeply anesthetized group. You can see a general gradient of increased cortical activity in the controls and increased subcortical activity under isoflurane anesthesia. We can take this analysis even further. On the far right, you see the heat map taking us into a deeper subdivision of brain regions within each of these general parent regions. And then we can go even further into this. One brain region in particular that stands out and is of interest is the ventral tegmental area. Here you can see the ATLAS registration in the coronal slice. It's difficult to see, and I don't think I have a pointer here, but the ventral tegmental area has increased activity in the control state, decreases in the deeply anesthetized state, and then increases again in the emerging state. And our findings parallel findings by other laboratories investigating this brain region, such as Ken Solt's laboratory, that showed that stimulation of the ventral tegmental area promotes emergence or arousal in mice, as well as arousal from sleep. The ventral tegmental area is a dopaminergic hub in the midbrain reward circuitry. So it sends dopamine to numerous different subcortical and cortical brain regions. This circuitry is important for reward, stress, as well as arousal. One of the brain regions it sends dopamine to is the nucleus accumbens. And so now that we have our whole brain map, we can go further and look at these discrete brain regions, such as the ventral tegmental area, taking advantage of other approaches that we can do in the awake behaving animal. For example, using targeted biosensor imaging. Here we're imaging D-light fluorescence. D-light is a sensor that fluoresces when dopamine is present. So we're imaging in the nucleus accumbens in a mouse that has undergone isoflurane anesthesia and then allowed to emerge. We see that there's an increase in dopamine release that precedes the time of emergence, which is shown by restoration of the writing reflex in the mouse. Overall, I'm showing you that distinct subcortical and mesolimbic brain regions show increased activity under the deeply anesthetized and lightly anesthetized or emerging states of anesthesia. The ventral tegmental area specifically shows significantly decreased activity under isoflurane and increased activity with emergence. And similar to what's been shown by other groups, we see that ventral tegmental area to nucleus accumbens dopamine projections are engaged in emergence from isoflurane in mice. Our future studies will dissect the relative contribution of activated brain regions to emergence. And we will also be examining the effects of age and different anesthetics, such as propofol, on neural activity across the entire brain. I'd like to thank my collaborator, Sam Golden, for his support of the whole brain imaging work, as well as Alex Murray, a research scientist who collected the whole brain data, Leandro Mangieri and Michael Brukas for their support of the fiber photometry work that I showed, as well as my funding from FAIR and the NIGMS. Thank you for listening. I'm happy to take any questions in the Q&A.
I'm just getting my slides up. Hi, everyone. What do you guys see?
You just need to click into presentation mode.
Okay, still How about now?
All set. Thank
Okay,
you.
great, thank you. Hi again. So I'm Kate Rosenblatt. Thank you, Brad, for the introduction before. I'm a neuroanesthesiologist and a neurointensivist. I'm actually really pleased to present some of the latest work from the Johns Hopkins Cerebral Autoregulation and Sepsis Research Group. My research is funded by the Foundation for Anesthesia Education and Research, and I have received honoraria from Massimo and MIT to participate in super user educational meetings. So the prevalence of sepsis in the United States is 3 per 1,000 people. And this is for those of you who don't know about sepsis. It is seen in a clinically diverse population. More than half of these patients need treatment in an ICU, and the overwhelming majority die within 3 years after having had sepsis, despite increases in short-term survival in the last 2 decades. Sepsis-associated encephalopathy, estimated to occur in up to 70% of patients with sepsis, is independently associated with increased mortality and long-term cognitive disability among survivors. This form of encephalopathy is an acute change in mental status in the setting of sepsis without direct evidence of central nervous system infection. Symptoms can vary from delirium to coma, with mortality rates over 60% in comatose patients with sepsis. People who have survived sepsis, especially those who have had septic encephalopathy, warrant special attention because evidence has emerged that many of them never fully recover. Survivors often have long-term disabling cognitive dysfunction and functional disability. Unfortunately, there are no precise, well-established clinical markers to guide cardiovascular therapy if sepsis-associated encephalopathy is suspected. As in sepsis, the manifestation of septic encephalopathy, the patients affected, and the course of illness are notoriously heterogeneous. The complex pathophysiology of septic encephalopathy is thought to involve direct and indirect toxicity in the brain parenchyma, disruption of the blood-brain barrier, mitochondrial and endothelial dysfunction, and neurotransmission disturbances. The effects of these mechanisms on autoregulation and brain perfusion may be substantial. And at present, there is no standardized method for continuously monitoring cerebral perfusion in ICU patients. But before I go further, please allow me to first remind you of the importance of cerebral blood flow autoregulation. The brain, more than any other organ in the body, requires a constant supply of oxygen and nutrients, as well as the removal of waste products. In healthy humans, this blood flow should stay approximately constant when blood pressure varies and should adapt to changes in energy consumption, carbon dioxide and oxygen levels in the blood, pressure inside the skull, and other factors. This regulation of blood flow is achieved primarily by arterioles dilating and contracting under the influence of multiple complex physiological control systems. An impairment of these systems may occur in many disease and physiologic states, and this impairment has been implicated in the development of subsequent brain injury. So we know that autoregulation is absent when blood pressure is below or above its functional threshold. And my colleagues at Johns Hopkins have shown that autoregulation seems to be completely impaired in about 20% of cardiopulmonary bypass patients during surgery. We also know that following traumatic brain injury and stroke, the capacity for autoregulation may be lost completely, or the thresholds for autoregulation may be reset. Our review of cerebral blood flow autoregulation and sepsis showed that autoregulation is impaired more often in patients with septic encephalopathy than in those without encephalopathy. Impairment of autoregulation during sepsis may be due to cerebrovascular dysfunction and microcirculatory changes, or merely from profound hypotension with cerebral hypoperfusion below the lower limit of autoregulation. And on average, mean arterial blood pressure of patients in the reviewed studies was maintained above 70 millimeters of mercury, suggesting that hypotension based on traditional definition is really an unlikely explanation. And alternatively, impairment may be due to shifts in functional thresholds of autoregulation with associated cerebral hypoperfusion or hyperperfusion occurring at uncharacteristic blood pressure values. And in this scenario, autoregulation is functional in sepsis perhaps, but only in a narrow window of optimal blood pressure values, which may change during the course of sepsis. And our preliminary data indicate that near-infrared spectroscopy in combination with continuous arterial pressure monitoring can determine an index of autoregulation called the cerebral oximetry index, or COX, and the optimal blood pressure for preserved autoregulation in patients with sepsis-associated encephalopathy. Now, pre-existing neuropathology and pharmacological sedation may influence the diagnosis of septic encephalopathy and perhaps autoregulation. So to reduce confounding in our preliminary work, we selected a cohort of patients with acute encephalopathy directly attributable to sepsis without neurological premorbidities or alternative causes of delirium. And we placed NIRS, near-infrared spectroscopy monitors, on these patients and monitored them for 12 hours. Autoregulation curves were constructed for each patient with average Cox values sorted by arterial blood pressure in 3 sequential 4-hour periods. The optimal pressure, or MAP-OP, defined as the MAP associated with the most robust autoregulation, was identified in each period. An hourly mean Cox was also calculated, and severity of encephalopathy was measured with the Glasgow Coma Scale. We found that disturbed autoregulation based on Cox was associated with worse neurologic status, both with and without controlling for age and severity of sepsis. And what this means is that with every 0.1 increase in Cox, you were twice as likely to have a GCS, so Glasgow Coma Scale, less than 13. And we were extremely certain of this. Notably, patients with moderate to severe encephalopathy did not differ from patients with mild encephalopathy on measures of MAP or regional oxygen saturation, RSO2, meaning hypotension and regional oxygen saturation of the cerebral cortex were not worse in patients who were more encephalopathic, as you would expect. So the purpose of our most recent work was to compare personalized autoregulation-guided blood pressure management with the commonly used clinical approach of maintaining blood pressure above a fixed predetermined value as recommended by current guidelines. And we evaluated the association between deviating from these blood pressure targets and clinical outcomes. So we concluded an initial analysis of which we screened 1,560 adult patients admitted to Johns Hopkins ICUs with sepsis. 1,481 were excluded for all these reasons listed here, and with the use of the IQ code screening tool in order to reduce the chance that encephalopathy or poor outcome or autoregulation disturbances may be attributable to non-sepsis factors. 79 patients were enrolled, but 14 patients were not analyzed due to insufficient monitoring time. Therefore, 65 patients were analyzed. The mean monitoring time of these patients was 12 hours. 18 subjects died during their hospital admission and 12 died after hospital discharge, but before 90 days. So for the determination of optimal mean arterial pressure, or MAP-OPT, on an individual basis, a MAP trend was recorded alongside an autoregulatory index Cox. Corresponding Cox values were averaged within 5 millimeter MAP groups, and using initially ICM Plus software developed at Cambridge in the UK, a parabolic curve was fitted to the bin blood pressure data to identify the MAP with the lowest associated Cox value. The MAP-OPT is the nadir of this curve, which corresponds to the midpoint of the classic autoregulatory curve. And limits of autoregulation were estimated by applying a threshold for impaired autoregulation, which was a Cox of 0.3 based on previous studies. And the blood pressure at which Cox crosses this threshold yields a lower and an upper limit of autoregulation corresponding to the region of the autoregulatory curve where cerebral blood flow passively follows changes in systemic pressure. And using a moving 4-hour window that was updated every 1 minute, a continuous time trend of the MAP shown in the white line, MAP-OPT shown in the yellow line, and the limits of autoregulation blocked in red was recorded. And in each patient, we calculated the percent time that MAP was below the lower limit of autoregulation, here shown with the gray shading, and above the upper limit of autoregulation, which did not occur in this patient during these 12 hours of monitoring. We also calculated the percent time MAP was within 5 millimeters of mercury of MAP-OPT, here shown in green lines, and within 10 millimeters of MAP-OPT, which is not shown in this graphic. And clinical outcome was measured using the extended Glasgow outcome scale at discharge and 90 days. Baseline characteristics of the patients at enrollment are summarized, but in the slide. Of note, though, that majority of sepsis patients were enrolled from our surgical intensive care units. Of the 35 patients alive at follow-up months, 30% achieved functional independence at 3 months. Patients with good outcome were younger and had lower admission Apache and SOFA scores as expected. They also had a lower incidence and severity of encephalopathy. The median percent time spent with MAP less than the lower limit of autoregulation among survivors was 9.7 compared to 14.2 among non-survivors. And the median percent time with impaired autoregulation was 10.2% among survivors compared to 16.4 in non-survivors. Results of the univariate analysis of predictors of outcome at discharge and 90 days are not presented for sake of time, but after adjusting for age, admission, Apache 2 score, and Charleston Comorbidity Index, the percent time less than the lower limit of autoregulation is independently associated with worse Glasgow outcome scale scores at discharge and at 90 days, as was percentage of time patients exhibited impaired autoregulation. And blood pressure within both 5 and 10 millimeters of mercury of optimal MAP were independently associated with more favorable outcomes. And although we observed a non-significant trend towards worse outcomes with increasing time below empiric MAP targets, the effect size was smaller compared to the personalized approach. What did we learn from this? Blood pressure below the lower limit of autoregulation, but not empiric MAP threshold, was associated with overall poor outcome. And this information is particularly important in the evolving landscape, I believe, of precision-based medicine, in which more high-frequency physiological data points are available to clinicians in real time. Further research is needed to test autoregulation-based treatment strategies, including tailored pharmacological blood pressure augmentation, and the determination of which autoregulation-based measurements should be targeted to improve outcomes. And thanks to FAIR, this is what we are currently working on using machine learning techniques and with an upcoming installation of advanced multimodality neuromonitoring devices. We will have synchronized high-frequency time series data from power spectrum analysis of sepsis study patients' EEGs to assist in detection of encephalopathy alongside simultaneous changes in cerebral blood flow autoregulation. And yes, we are building up for a randomized trial, but first we need to test, well, I'd say we need to best determine which individualized measures to target. And that concludes my presentation. I really thank you for your time, and I look forward to hearing your comments and answering questions later.
All right. Hi, everyone. Let me get my presentation up and running. I'm Mike Devinney. I'm an assistant professor at Duke, and I'm going to talk about results from our SANDMAN study, which investigated the role of preoperative sleep apnea and excessive daytime sleepiness in postoperative neurocognitive disorders. My disclosures are here. The study was funded by a FAIR Research Fellowship grant, and I do receive funding from the NIA and FAIR for a GEMSTAR grant. And my spouse owns an equity share in an employer that makes personal care products that are unrelated to this research or this presentation or any of my research. So what are postoperative neurocognitive disorders? They were touched on in Dr. Rosenblatt's talk in terms of sepsis-induced encephalopathy, but I'll be talking about postoperative delirium and postoperative cognitive dysfunction, which since 2018, postoperative cognitive dysfunction has been renamed postoperative neurocognitive disorder. And really the main distinction is the timing of when these occur. So delirium is characterized by acute change in attention, awareness, and thinking that occur typically 1 to 3 days after surgery. Postoperative neurocognitive disorder is a change in cognitive abilities or thinking and memory that occur at least 30 days after surgery and are associated with some subjective or objective cognitive impairment, like subjective cognitive complaints or deficiencies in instrumental activities of daily living. And these are both important to prevent because, one, they're very frequent in our older surgical patients. They can happen up of between 20 to 40% of older surgical patients experience one of these disorders. And they're associated with decreased quality of life, longer-term cognitive impairment, and increased mortality after surgery. So how does sleep apnea factor into this? Well, sleep apnea, which many of you know, is due to intermittent obstruction of the airway at night that results in intermittent hypoxia and sleep disruptions. Sleep apnea has been associated with neurocognitive impairment outside of surgery. It has been associated with mild cognitive impairment, dementia, and increased Alzheimer's disease neuropathology. Sleep apnea also has been associated with increased stroke and then many other potential neurologic mechanisms that underlie both postoperative neurocognitive disorders and neurocognitive impairment outside of surgery, such as blood-brain barrier breakdown and neuroinflammation, even altered cerebral autoregulation and sympathovagal imbalance, and disrupted brain bioenergetics. These mechanisms could all contribute to worse cognition. So we really wanted to determine, is sleep apnea and increased preoperative sleep apnea severity, undiagnosed sleep apnea, untreated sleep apnea, associated with increased neurocognitive disorder. And our main outcome in this study was neurocognitive disorder severity, or decreased global cognition at 6 weeks after surgery. That was our primary hypothesis, is that sleep apnea, untreated sleep apnea, would be associated with decreased global cognition at 6 weeks after surgery. A second hypothesis is that increased sleep apnea severity would be associated with increased postoperative delirium severity. And we targeted these severity metrics instead of incidence because, one, it allows for increased statistical power. Two is that these disorders really do exist on a spectrum, that some patients will have subtle attention deficits and some will have really severe representations of delirium with really severe inattention and alterations in their awareness. The third aim, which I'm not showing here, is really to determine the relationship of sleep apnea with neuroinflammation as measured by increased CSF cytokines, cerebrospinal fluid cytokines. This, has implications for neurocognitive impairment outside of surgery and other ways that sleep apnea causes neurologic dysfunction, but also for postoperative neurocognitive disorders. But I don't have time to get into that today. So the way we did this is, this was a sub-study of my mentor's Intuit study, where patients age greater than 60 that were scheduled for non-cardiac surgery were recruited. We excluded them if they were treated for sleep apnea within the last 3 months to minimize confounding by sleep apnea treatment. They underwent home sleep apnea testing with this device that measures both pulse oximetry as well as chest movement for respiratory effort and nasal cannula airflow for respiration. And it can tell you the number of apneas and hypopneas that the patient's experiencing per an hour. We also tested the patients using a in-depth baseline cognitive testing panel, and we assessed them for excessive daytime sleepiness using the Epworth Sleepiness Scale. So 96 patients had adequate home sleep apnea testing data. And then after surgery, we performed postoperative delirium assessments with a 3D cam twice daily up through post-op day 5, and 90 patients had at least one completed delirium assessment. And when patients were present in the hospital, we had a really good rate of completion of delirium assessments. The ones that didn't complete were patients that were typically discharged before post-op day 1. And then we repeated cognitive testing at 6 weeks after surgery, and this allows us to look at the change in cognition from before surgery to 6 weeks after surgery. And so what did we find? Well, the home sleep apnea tests were interpreted by our collaborating sleep physician, Dr. Andrew Spector, and he found that 60% of the patients we tested had some form of sleep apnea. So a huge number of these older adults, or these are age greater than 60 patients, and 24% had moderate to severe sleep apnea. And we were able to put these in the patient's charts, diagnose them. They were arranged for follow-up treatment evaluation, but this occurred after the 6-week period. So no patient had gotten sleep apnea treatment before their 6-week cognitive testing. So what did we find? Well, we found that sleep apnea was actually not related to neurocognitive disorder severity. And I'm showing that here as 6-week global cognitive change on the y-axis. So patients that had a decrease here or lower had a decrease in their global cognition or had some impairment at 6 weeks. And then some patients actually had some cognitive improvement at 6 weeks. But there's no relationship to our main measure of sleep apnea severity, the respiratory event index. This really is the number of apneas and hypopneas per an hour. It's similar or analogous to the apnea-hypopnea index. It just tends to underestimate it because we don't measure sleep like an in-lab polysomnography test does. And if we build this into a multivariable model, we find that so that this is really unadjusted on the left, we find that there's really no relationship with our main measure of sleep apnea severity with postoperative neurocognitive disorder severity. But we do find, things that have been shown before. Increased age is associated with lower 6-week cognition or decreased cognition at 6 weeks. And increased baseline cognitive index is associated with lower cognition at 6 weeks. If you start off higher, we've seen this before in some of our other studies, you start at higher cognitive performance, you have more to lose. So we tend to see more decrease in those folks. What about delirium? So, I showed you that sleep apnea is not really associated with postoperative neurocognitive disorder severity. And we had also, I should mention, looked at incidence of postoperative neurocognitive disorder in our study. We found no relationship with sleep apnea there, and I don't have time to show that data today. But in terms of delirium, we also looked at delirium severity as a measure, peak delirium severity scores after surgery. And we found no relationship again with sleep apnea severity and peak delirium severity. And if we build this into a model, we see things that we commonly see. Increased surgery duration is associated with a greater odds of having higher peak delirium severity, and a higher baseline cognition is actually protective for delirium. So lower baseline cognition is one of the major risk factors for delirium. And we see here that in our model, it is, again, one of the biggest factors. But we see no evidence relationship of respiratory event index or sleep apnea severity with delirium severity. So this was somewhat surprising. We had also planned on analyzing our excessive daytime sleepiness data because patients with sleep apnea and excessive daytime sleepiness have greater neurocognitive impairment, and it's really thought to represent some form of neurologic injury. So we went ahead and analyzed excessive sleepiness, and we were surprised to find that excessive sleepiness is actually associated with greater delirium severity. So these are patients who had an Epworth sleepiness score of greater than or equal to 13. This is similar around a level of sleepiness that patients with narcolepsy have, but no patients in the study were diagnosed previously with narcolepsy. And it's unlikely that all these patients had narcolepsy. But we did find that a statistically significant association, a univariate association of moderate severe excessive sleepiness with peak delirium severity. And if we build this into the model with the same covariates, we find that there is a strong trend for moderate severe sleepiness to be associated with greater odds of having higher delirium severity. And there's actually a little bit of a negative trend for having sleep apnea being protective for greater delirium severity, which is a little bit somewhat interesting. And again, we see increased surgical duration, increased cognitive index, or increased baseline cognition, or lower cognition being a risk factor for increased delirium severity. And then what about excessive sleepiness and postoperative neurocognitive disorder? Well, we showed that here we see that moderate severe excessive sleepiness, patients with moderate severe excessive sleepiness have lower 6-week global cognition compared to normal, but this wasn't statistically significant. But if we build it again into our multivariable model, we find that moderate severe excessive sleepiness is actually associated with lower 6-week cognition or 6-week global cognitive decrease, which is interesting. So it seems that excessive sleepiness, independent of sleep apnea, is associated with increased risk of postoperative neurocognitive disorders. These results, are in a relatively small sample. I think about 13 patients had moderate severe excessive sleepiness in our study, and so this is preliminary, but it really raises the question, is there something about excessive sleepiness that increases neurocognitive disorder risk? And what is that? And, I think some things that we should consider are prodromal neurodegenerative diseases. We know that older adults start to have excessive sleepiness, and it could be multifactorial in nature. But one thing is, as someone develops Alzheimer's disease in the early stages, they have excessive sleepiness. Another thing could be sedating medications. We're doing some further work with that. And finally, sleep deficiency should be considered. Maybe some patients come in who are deficient in sleep and have excessive sleepiness from not being able to get sleep for some reason, are at increased risk of delirium. But I think we should also consider some limitations here. We diagnose sleep apnea using home sleep apnea tests. I think this is a relatively minor limitation. We diagnose 60% of our patients with sleep apnea. We found a high burden. If anything, they tend to underestimate the severity of sleep apnea, and one would tend to believe that it would underestimate it in patients somewhat equally. So I think that it is a minor limitation. Another factor is we really don't know when these older surgical patients develop sleep apnea. Many of them could have developed in an older age. They might not have really suffered a significant hit to their brain from their sleep apnea yet. And it may be different phenotypically than patients who develop sleep apnea in middle age and have excessive sleepiness. Another thing I didn't mention is that many of our patients with sleep apnea did not have excessive sleepiness. So it seemed like they weren't really suffering many of the neurocognitive consequences that people that develop sleep apnea in middle age suffer, which they tend to have more excessive sleepiness. And then we did have a low incidence of neurocognitive disorder and delirium. We had 11% delirium rate, about a 15% neurocognitive disorder rate. So, you could say we're slightly underpowered to do those analyses, but we were powered for the determined relationships with severity. And then I would say that sleep apnea still could be associated with cognitive outcomes in different settings. Our patient cohort were pretty much cognitively intact. We didn't have patients with baseline cognitive impairment. Sleep apnea could affect patients with pre-existing cognitive impairment differently and put them at greater risk. Further, sleep apnea could interact with the surgical hit to produce greater risk for neurocognitive disorders, such as cardiac surgery with cardiopulmonary bypass. And so we studied, a wide variety of non-cardiac surgeries here. And so just to conclude, surprisingly, untreated sleep apnea is not a major risk factor for postoperative neurocognitive disorder or delirium. And I think this raises important questions as to why. I covered some of those, but another thing we could speculate is maybe sleep apnea does have some protective effects. Maybe there is some hypoxic ischemic preconditioning effects that are counteracting some of the negative effects sleep apnea has on the brain that in those sort of interactive help decrease risk for postoperative neurocognitive disorders. This is all just speculation. And then, further studies, I think, need to investigate this relationship of excessive sleepiness and try to figure out why this is the case and replicate it in a larger cohort. And really, we should try to determine if we could use it to risk stratify patients for perioperative neurocognitive disorders. I just wanted to acknowledge the funding support, FAIR, for funding the SANDMAN sub-study, the wonderful team I have at Duke, and my mentors, especially Miles Berger, who allowed me to do the sub-study to his K76 funded Intuit study. And thank you. I look forward to your questions in the Q&A.
All right. Hello, everybody. Can you see my screen all right?
Yes, it looks good.
All right. Well, thank you for joining us during this perioperative brain health webinar. My name is Kendall Smith, and I'm an assistant professor at Washington University in St. Louis. And today I'm going to tell you a little bit about my work to understand transcriptomic circadian rhythms and relationships to postoperative delirium. I did receive support through the Washington University Department of Anesthesiology T32 program between 2019 and 2021. And I was also very fortunate to receive an IARS Mentored Research Award last year. So I think that we're all pretty familiar with postoperative delirium in this group. It commonly affects older adults, as Dr. Devinney mentioned, in patients who are undergoing major surgery and anesthesia with increased morbidity and mortality. One of the challenges that we face with postoperative delirium is that its pathophysiology is really poorly understood, I think, as Dr. Devinney also mentioned. And we think in part that's probably because its etiology is likely multifactorial. What I'm going to talk a little bit about today is thinking of postoperative delirium in terms of having circadian rhythm disruption as a putative contributor. And here we're looking at just sort of delirium and all the different signs and symptoms that patients experience. And altered sleep-wake cycle is definitely one of those that is commonly observed. So in terms of circadian rhythms, most people think of circadian rhythms as rhythms of sleep and relate it to sleep timing, and that's true. Circadian rhythms are really important for timing of sleep. But it's not just sleep, actually. Circadian rhythms are important for most biological processes and the timing of most of those processes. And so I want to go through a little bit about how that works. Light actually in most organisms is the primary zeitgeber or time giver. And that light information is received through the optic nerve to the suprachiasmatic nucleus, which is thought of as the master clock of the body. The SCN then will send information to different clocks, both in the brain. So there actually are peripheral clocks located in the brain and other regions of the brain, and also in the peripheral organs. Now, how does this actually work? Well, it turns out that there is a very elegant transcriptional feedback loop that actually governs this process through a core set of clock genes. And here I'm just noting Drs. Hall, Rosbash, and Young, who won the Nobel Prize in 2017 for their years of work in elucidating this core clock machinery. But it turns out that it's not just the clock genes that oscillate, but in fact, up to 50% of the human transcriptome oscillates in a circadian fashion. And it's thought that this is actually what allows us to synchronize our organ systems and behavior. And one of the things that I'm really interested in doing is understanding the impact of major surgery and anesthesia on circadian rhythmicity and perioperative brain health. So looking at the relevance of circadian rhythms and perioperative brain health, we know that circadian rhythm disruptions are seen in both chronic and acute CNS disorders. And typically, in terms of circadian rhythm disruptions, we see a decreased amplitude in rhythms, increased fragmentation of rhythms, and also extremes of phase angle. In other words, very early or late chronotypes are associated with CNS disorders. Now, typically, circadian rhythms are investigated using actigraphy, which is the study of rest activity patterns, or dim light melatonin onset, which is sort of the gold standard for circadian phase. Now, a very interesting point, we also know that general anesthesia is actually a clock disruptor. And for more information on that, I would refer you to Dr. Guy Warman's publication and lab from the University of Auckland. It's very fascinating. But in terms of looking at studies linking acute circadian disruptions to postoperative delirium, actually, when you look in the literature, most of the studies tend to be smaller scale. They tend to lack granularity. And then I think it's important to note that there are significant challenges to interpreting these studies using actigraphy as well as dim light melatonin onset in hospital settings. When we think about it, our hospitalized and critically ill patients are commonly immobile, so it's really hard to interpret actigraphy. And oftentimes they're exposed to lighting at all odd times of day, and sometimes that's just unavoidable due to healthcare needs. So one of the things that I'm really interested in doing is seeing how we can leverage rhythmic gene expression as a feasible and comprehensive measure of circadian integrity. So how do we do that? Well, it turns out that there are several algorithms that allow us to do just that, actually. And so I'm going to talk just a little bit about one algorithm that I've been using, which is called time signature. And in a nutshell, time signature is a machine learning algorithm that allows you to accurately predict internal clock time of a person using gene expression data in human blood. Very briefly, you give time signature gene expression data, and time signature will spit back out the estimated internal body clock time of the person. So this time signature was developed by Dr. Rosemary Braun at Northwestern University, and this is just a figure from her paper in PNAS of 2018 that describes the method. On the x-axis, we're looking at true time of sampling versus on the y-axis, which is the transcriptomic time estimated by time signature. And as you can see, most of the dots are falling within the dark or the light gray bands, which represent accuracy either within 2 hours or 4 hours. So I don't have time to talk all about time signature, but there are a few advantages that I want to point out. First of all, it's generalizable. You can apply it across platforms without extensive recalibration. And also it requires only 2 samples of blood suitably spaced. And so I think that these highlight really the potential for using this in our inpatients and our hospitalized patients. So very briefly, the first thing that we did was we wanted to validate time signature use in older adults and its accuracy. And very briefly, we did find that time signature accuracy was maintained. And the results of the study was published this summer in Sleep. We also found a nice correlation between the AM and PM transcriptomic angle. which demonstrated algorithm robustness. And we also noticed that there was some spread in the data. And we hypothesized that maybe those individuals who whose internal body clocks were later than the true time of sampling, maybe those were our morning larks. And maybe patients who had predicted times that were earlier than the true time, maybe those were our night owls. And just very briefly, what we found was that did actually correlate quite nicely with traditional measures of circadian phase. And so that gave us confidence that time signature is an objective molecular method to estimate internal phase. So transitioning that into the perioperative world is one of my main goals. And so this study was funded by the IARS through a Mentor Research Award last year. And what we really wanted to do was characterize transcriptomic rhythms in older adults undergoing elective cardiac surgery, and then look at relationships to postoperative delirium severity. And here you can see just an overview of the study. It's actually a sub-study of an R01 funded study from Dr. Ben Polanka, who's looking at EEG markers and relationships to delirium. And so what I want to do is add a molecular arm onto his R01 funded study. And I hypothesized that maybe, we might find 2 or more different types of categories of patients. And let's say hypothetical patient A versus B. And in the blue here, we're looking at perioperative transcriptomic rhythms, where the blue waveform is sort of a representative example of perfect alignment with clock time or true time. And the red dashed waveform is sort of the hypothetical patient A. And we hypothesized that perhaps maybe some patients we would find wouldn't have much of a change in angle based on before and after surgery. But maybe we would identify a subset of patients who did have a dramatic change in transcriptomic angle. And so that was our first aim. And then our second aim was really to look at whether or not there are relationships between neurocognitive outcomes. So I wanted to share with you all some of our preliminary data. This is very new. We are very excited to say that we have obtained pre- and postoperative blood samples from 22 individuals who've undergone elective cardiac surgery. And we got AM and PM samples from the day before surgery on postoperative day 1. And then 10 individuals, we got AM and PM samples from postoperative day 4. We've identified a delirium incidence of 45.4% in this cardiac surgical patient population, which is consistent with national estimates. And we use twice daily assessments on postoperative day 1 through 7 using the confusion assessment method or the CAM-ICU. And in terms of differences between the 2 groups, between delirium absent, delirium present patients, I would point out that patients who did experience delirium did have longer mean length of surgery, longer mean length of cardiopulmonary bypass time, longer aortic cross-clamp time. Time intubated was longer in these patients, and they also had a longer ICU length of stay. So in terms of results, we were really excited to find this and to kind of get these data. But what I just want to orient you first. We're looking on the x-axis. We're looking at our three different time points. On the evening, on the night before surgery, we're looking at postoperative day 1 in the middle and postoperative day 4 on the right. And on the y-axis, we're looking at the transcriptomic angle, where 0 would be perfect alignment with true time. And what we were really excited to see was that a significant amount of variation in our data set, where initially we see a nice hovering around 0, but in a subset of patients, we see significant phase delay, actually, while other patients tended to remain relatively stable. And then in some individuals, we found a really interesting pattern where patients would return back towards their baseline on postoperative day 4 in those 10 individuals where we performed RNA sequencing on those. So if you think back to our model, I think what we could be seeing are sort of different phenotypes of patients who are undergoing changes in their circadian rhythms perioperatively. And this is really, to our knowledge, one of the first characterizations of changes in circadian rhythms across the perioperative continuum. Now, I would say we should proceed with caution in terms of interpreting these results. I mean, obviously, I think differences in these different characteristics, I mean, we, of course, are looking at delirium severity as a future direction and trying to understand the clinical significance. but also, it could be because of differences in perioperative characteristics or differences in, for example, quantity of perioperative blood product transfusion. And that's something that we're looking into now. So in terms of next steps, I've been very fortunate to be able to work very closely with Dr. Braun. And so we're continuing to work on optimizing the algorithm. We're also interested in relating those results to postoperative delirium severity and also longer-term neurocognitive outcomes. We also want to do some other really cool things with our very rich longitudinal RNA-seq data set, including performing differential gene expression analyses and gene set enrichment analyses between the two groups. And then finally, we're really interested in examining relationships with protein biomarkers of inflammation. So in summary, I hope that I've been able to convey to you that circadian rhythms are likely important for perioperative brain health, and especially in older adults. And new transcriptomic methods will allow us to examine for the first time how circadian rhythms change across the perioperative continuum. And in the future, we're going to work on relating those changes and perturbations to outcomes of interest. So I thank you for your time, and I want to thank and acknowledge the community who's helped me here at Washington University. I don't think I could have done this anywhere else. Again, happy to take questions in the Q&A.
Excellent. So now we're going to transition into our question and answer time. And we do have quite a few questions that have come through the Q&A session already. My first question is for Dr. Rosenblatt. Can you comment, does metabolic acidosis play a role in the pathophysiology of sepsis-associated encephalopathy?
That's a great question. I have personal beliefs, and I don't think we're yet there with evidence. However, we do know a little bit about cerebral blood flow and metabolic acidosis and increases in flow and pressure. And we do know that it really does not affect a lot of your cerebral blood flow, where you can have some profound metabolic acidosis and it won't increase your cerebral blood flow. And it's related to the mechanism of hydrogen transport. And we do know that, respiratory acidosis would increase your blood flow. So personally, based on that data, I don't think so. However, the metabolic derangements associated with it, all of the other ionic gradients are perhaps affected, and I would suggest that it could be not directly related, but indirectly in that mechanism to affect, cellular health overall.
Thanks. Next, we have a question for Dr. Heshmati. Can you elaborate some on the clinical implications of a lot of the mechanistic work that you're currently doing?
And the goal of this preclinical work is to really identify the patterns of brain activity that are activated with isoflurane anesthesia, in the hopes that we identify the neural signatures engaged by anesthesia. As I mentioned, the work that our research is discovering these mechanisms at the cellular level, so we can then identify specific receptors or other substrates that we can target therapeutically, which is a ways off, but first we have to do this work.
Great. So next, a question for Dr. Devinney. So could some of the excessive sleepiness that you're observing be related to mental health factors, such as anxiety before procedures? And did you measure any quality of life assessments to associate with excessive sleepiness?
Yeah, that's a great question. I mean, excessive sleepiness is really multifactorial, and I really do think that there could be psychosocial impacts, other things. We did not see, a strong relationship between health-related quality of life metrics, and we also did SF-36 and state trait anxiety inventory. I didn't show any of that here, so we didn't see any relationship with delirium or postoperative neurocognitive disorder with those metrics. I don't know if we saw excessive sleepiness, a relationship with those metrics of excessive sleepiness, but I don't think they're major confounders between excessive sleepiness and postoperative neurocognitive disorders, at least in our data set. But I think it's a really good question. We don't know why these patients are excessively sleepy, and I think that's a really big question for your future research. Like, what is making these older adults excessively sleepy, and what could we do to intervene on that? And would it actually address delirium risk factors or neurocognitive disorder risk factors before surgery. And I think some of it might need to be multi-component and address, quality of life and psychosocial issues too.
Thank you. Next, I have a question for Dr. Smith. So one of our attendees was asking, if patients are undergoing cardiac surgery and they remain sedated postoperatively in the ICU, how does the timing of your postoperative blood sample relate to any ongoing sedation?
So we wanted to keep things pretty consistent in terms of timing. And so regardless of whether or not the patients were still intubated on postoperative day 1, we still collected the samples on the morning and evening of postoperative day 1. But I think the attendee brings up a really good point, which is why I think that postoperative day 4 sample is also important. But as you also remember, I mean, we saw a good degree of variation regardless of, postoperative day 1 versus postoperative day 4, where some individuals had a significant change while others did not. But that's a great point.
So another question for Dr. Heshmati. Can you comment your thoughts about the amygdala, given some existing studies showing connected consciousness with the isolated forearm technique under anesthesia, where you have responsivity but not explicit recall?
So my interpretation of this question is, why is the amygdala active when it's a canonical stress brain region? And our first thought when we saw this pattern of activity was, oh, we're capturing activity during induction. Maybe the mice are just panicked, and this is a reflection of their anxiety going under anesthesia. Well, what data that I didn't show is we actually also collected time points much later out past that initial CFOS window, and we continue to see increased activity in the central amygdala as well as the BNST and other canonical stress brain regions. A more interesting hypothesis that we'd like to explore is perhaps these patterns of activity help predict later emergence agitation. And we have yet to we have to answer that question, but our next step is to repeat these studies with propofol and see if we still see similar patterns of activity in these stress brain regions.
Thanks. And I think we have time just for a couple more. I know we were a little bit past the hour, but we have some good questions still here in the Q&A. For Dr. Devinney, age is a well-established risk factor for delirium. And the person asking the question always uses age as a positive control to check for other signals. And in your presentation, age did not appear to be significant. Do you have any comments on that observation, and how might that impact your overall results?
Yeah, so we recruited patients that were age greater than 60 for the study undergoing non-cardiac surgery, and so we don't really have a wide age spread in our and I didn't really show that sort of table 1 that you see in manuscripts that show kind of the demographic factors just to save time, but because we don't have a lot of patients that are like age 80, and we really are kind of grouped between like age 60 to 70, I don't think we can really resolve in this like N of 96 an effect of age, and I think that's probably why we're not seeing it with delirium and delirium severity here. But that being said, we do see some things with baseline cognitive impairment. We did see age as a risk factor or an association with decreased global cognition at 6 weeks. So it's probably some noise in a small sample and restricted age range in our data set. Well, thank you for the question.
All right. A question for Dr. Smith. Sometimes excessive sleepiness can change your circadian rhythm. Can you comment if this relationship is important in post-op neurocognitive disorders?
Yeah, I think that is a very great question. I mean, I would argue that yes, it is important for postoperative neurocognitive disorders, and that's really why I'm interested in studying it. I think the idea of age is interesting. I think and the relationship between sleep and circadian rhythms is also interesting and not fully elucidated. But older people we know have sort of quote weaker circadian rhythms, and so in a sense, oftentimes they may have slightly more fragmented sleep. And so I think it's an open question as to whether or not that might predict worse neurocognitive outcomes. And we are collecting the data for that for longer term studies at this time. Yeah.
All right. Well, thank you so much to all of the panelists for really wonderful presentations, and to everyone in attendance, both for your time and excellent questions. And thank you to IARS for sponsoring this webinar. We're very grateful to the opportunity to present and to connect with everyone. And I believe that if you do have other questions that you think of after the session, I'm sure that we're all open to ongoing communication afterwards. We would love to hear from you. So thank you to everyone, and we look forward to seeing everyone at another webinar or in person at the next conference. Thanks.